in just a couple of minutes. I'm putting it on YouTube now. Okay. Okay, you ready? Okay.
Yes.
Okay, here we
Yes.
go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the honor of having Suresh Dugani. I was browsing the internet, and as I was telling Harshad, I was struck by the amount of work that Dr. Suresh has done on his channel, because I know the amount of work it takes to put those channels together, and we appreciate him coming. And what we're also going to do today is try to get an interactive atmosphere with the panelists so they can get to know Dr. Dugani and ask him pointed questions. You don't have to come on the screen. You could ask it just in the chat, or you can ask him personally by video or just an anonymous chat. That's fine. And also we have our old friend, Arshad Parekh. He's been a long time user of this platform, and we appreciate him coming here to introduce Dr. Dugani. Welcome, Arshad.
Thank you, John. And good morning, good evening, good afternoon, wherever people are from joining from. It's my privilege and pleasure to introduce Professor Suresh Dugani, whom I know since many, many years. And his work is phenomenal. His technique of surgery is tremendous. And he takes a lot of pains to put his videos and shares with everyone. And it's a great learning for everyone, not only for youngsters, but also for the seniors. So it's always a pleasure to watch. And he's been at Hubli place in Karnataka of India, and where he's a professor as well as in his private practice and doing wonderful job. Yeah, I've seen his work being presented in many meetings, of course, YouTube and many webinars. So I look forward to see the Professor Dugani's work. Dr. Dugani, it's all yours now. Please start. Dr. Suresh, can you hear us?
Not yet. Can you guys hear?
I can hear you.
Okay, I think we may have lost him. Just give us a second. Suresh, are you there? sometimes you can access Sandeep. Hi, Dr. Sandeep. Do you want to come in? Okay, let me let you in here.
Thank you, sir. Thank you.
Oh, okay, you're in there? Okay, we lost our speaker. He'll come back.
Yes, sure, sure.
I gotta watch the participants and make. What part of India is the doc in?
It's from Karnataka, place called Hubli and Dharwad.
Is their internet
It is-
service pretty good or?
Yeah, it's very good services. Karnataka is one of the most popular place and big place. It's one of the states, southern states of the India.
Yeah, well, just be
I sent him a
patient.
message. Just sent him a message to join again.
Okay, yeah. Will do. Yeah, I just wrote him on WhatsApp. I find that's the best. Be patient, just check your email or something. I've written him on WhatsApp. I hope there's no catastrophe or storm. He should be corresponding by WhatsApp.
I spoke to him just now.
Oh, okay. He said he's coming
Yeah,
back.
some network is, yeah, he joined again. Yeah. Okay.
Okay. Oh,
Hi,
here he is.
Suresh.
Welcome back. Okay, it's all yours.
Hello.
Yes.
Suresh, can you hear us?
Yes, I can hear you.
I just
I'm
introduced
sorry.
you.
Some network issue. I think the network went off. I'm
Okay, no
sorry.
problem.
Yeah, thank you very much, sir. Thank you. Thank you.
I just introduced you. You are from Hubli, Karnataka, and being professor at medical college and doing wonderful job. And I have seen your all videos, all work, and various webinars, and also in the meetings you are presenting your wonderful job work. So we look forward for to see you.
Thank you, sir. Thank you very much. Thank you.
Please go ahead.
Yes. Please.
Okay.
Shall I share the screen or?
Please
Yeah,
share your screen.
yeah,
We'll
please.
start.
We'll start. Yes.
Oh, you getting a screen, Doc?
Yeah.
Okay.
I'll start the video presentation.
Yes, please start.
Yes.
Okay.
Are you going to share the screen, Doc?
Yeah. Just a minute. Just a minute.
Okay.
There's some network issue. I think it's troubling me. I'll just 1 minute. I'll just start with that.
Okay, so do you know how to screen share?
Yep.
Okay. But I'm not seeing anything. It looks like you're not trying to
No,
screen
I'm
share.
doing.
Yeah, you gotta, I should be able to see if you're trying,
Yes.
you're not even
Yes.
trying to share the screen.
Yes.
Click the share button. You got the share button there at the bottom of your screen.
Yeah.
Okay, click that. You haven't clicked that. I don't see it. You haven't clicked it. You need to click that share button.
Yes. Yes. Can you see that?
Yes. Okay, you make it presentation mode, please. Large size. It's not the large size, sir.
Yeah.
It's not the correct size. You need to take a presentation mode, which is at the, yeah. Could you explain, Harshad, where the presentation mode is?
Yeah, I can see his pictures. Tuberculum cell meningioma pictures are there.
Yeah, that's it. At the bottom of the screen there, down around there, it should be a screen that makes it large screen. No,
Okay.
but yeah, that's it. There you go.
That's it. Yeah,
There you go.
Suresh, are you talking? We can't hear anything.
You're not hearing?
No, oh, now we can hear you. Now we can hear you.
Now I can hear. Yeah.
Okay. Now, can you hear me now?
Yes.
Yes. So I'll start from beginning. Yeah. This is an educative video of a microsurgical management of tuberculum cell meningioma. This 43-year-old lady presented with diminished vision of 6 months, left eye more than right eye. GCS was 15, no neurological deficits. Left eye had perception of light, right eye finger counting. Front eye showed bilateral primary optic atrophy with field defects temporal. She was investigated with CT scan brain, MRI scan brain, MRI angiography. Showed a large tuberculum cell meningioma, 3.5 by 4 centimeters by 4.5, as shown in this. The CT images brilliantly enhancing, and MRI shows the location of the lesion with going posteriorly and pressing the midbrain, thalamus, and hypothalamus and optic chiasma elevation. She was taken up for surgery, underwent left frontotemporal pterional craniotomy, as shown here with a free bone flap. And we prefer to do the pterional craniotomy in all these cases. Once the bone flap is elevated, the most important step here is to drill the skull base, is of utmost importance. The sphenoid wing, the lateral sphenoid wing and the medial sphenoid wing are drilled flush with the anterior and middle skull base. This is of utmost importance because subsequent stages of the surgery, we need to go to the skull base, and at that juncture, we need to elevate the frontal lobe. By doing this bone work, the pressure and elevation of the frontal lobe and sylvian fissure becomes very less. The more we do the bone work, the more comfortable we will be at the subsequent stages of dissection. This is of utmost importance. One must take a little time and keep doing the bone work, the skull bone work. Go up to start with the lateral sphenoid wing, drill the medial sphenoid wing, and go medially up to the tuberculum sellae and the anterior clinoid. This is of utmost importance. Now you see, once we do that, then the dura mater is open with a base towards the skull base as shown here. Now this is the dural opening, a small dural opening, which centers around the sylvian fissure as shown here. The dura mater is hitched to the temporalis muscle. Now I want you to see, once this process starts, we need to do it under high illumination and high magnification. These lesions, we prefer to open the sylvian fissure deep and wide and lateral to medial as shown here. Once we do that, start from lateral end, go to the medial end and join the medial sylvian fissure, and open the keratico-optic cistern, and you can see the optic nerve there, and you can see the tumor originating from the tuberculum sellae region as shown here, and you can see the origin of that. The most important next step is to devascularize the origin of the tumor. The more you devascularize and the vascularity is reduced, the more comfortable you are in the subsequent stages of resection as shown here. Take a little time and a high illumination, as I mentioned to you earlier, and high magnification. Keep coagulating and separating the origin of the tumor from the tuberculum sellae region or plenum sellae region or diaphragma sellae region. It's very difficult in supracellular tumors to know where exactly they are originating. But even though the plenum meningioma, tuberculum sellae meningioma, diaphragma sellae meningioma, the approach is going to be the same. Now, as you see here, we are detaching the tumor from the origin, at the same time coagulating the feeders coming from the meningeal branches of the skull base. Probably they will be the meningeal branches of the middle meningeal artery. Now you see we have done a significant devascularization of the tumor and separated it from its origin. Once we do that, you can see here the tumor appears to be more originating from the right side of the tuberculum sellae region there, and where it appears to be more vascular and thickened and hyperostotic. Now we have almost near total devascularized and separated from the skull base. Once we do that, then we start dissecting the tumor. The advantage of this axis, trans-sylvian axis, gives us multiple accesses here. One, to start with, we can do inter-optic corridor or inter-optic approach. Second, we can do the keratico-optic corridor or keratico-optic approach, retrocarotid corridor, retrocarotid approach. Now we have opened the capsule of the tumor, but here tumor appears to be quite firm and vascular. So in such cases, we need to be very gentle and slow and keep dissecting and taking out the tumor under high illumination and magnification. This process is called, we call it debulking the tumor, is of utmost importance. See, we must remember.
Excuse me, Dr. Dugani?
Yes.
Yes, does anybody have any comments or questions so far they would like to
Yes.
ask Dr. Dugani?
Yeah, please go ahead. You can.
You can
Go
text
ahead.
the question if you want,
Yes.
or you can come on camera.
Yeah.
Anybody have any comments or Harshad, anybody?
No, Dr. Suresh is done very well. He has devascularized the tumor, wonderfully done. And he's just separating the tumor from the surrounding structures and debulking it. Very nicely going on.
Thank you.
Okay, I guess we'll continue on, Doc.
Yes.
Continue.
Thank you.
Please continue.
Yeah. Thank you. Thank you. So once we do that, and here you see the one, we must remember the operative field here is 1 square inch. And in that 1 square inch, we have a very vital life-threatening structures like internal carotid artery on both sides, hypothalamus superiorly, circle of Willis, that is anterior cerebral arteries, middle cerebral arteries, and optic nerves are hardly in a millimeter distance. So creating a space for the dissection is of utmost importance as shown here. Once you start debulking, gently the tumor capsule from superior aspect starts separating as shown here. As it starts separating from the subfrontal region and the optic chiasm and optic nerve superiorly, again devascularize the capsule of the tumor, and we can use surgical ultrasonic aspirate if the tumor is soft. If the tumor is firm, then we can use the soft tissue debrider and debulk the tumor. Now I want you to see, as we keep debulking, the tumor capsule starts separating from the optic chiasm, optic nerves on both sides, and starts easily separating down as shown here. Now this is the surface of the tumor. Again, at every stage, keep coagulating the capsule of the tumor. And my suggestion to all the younger generation of neurosurgeons is that keep the operating field very clean and neat, because see, we must remember we are dealing with the very vital structures, and if there is no clarity of the anatomical structures, we may injure inadvertently the important structures like optic nerve, carotid artery, and optic chiasm, and the anterior cerebral artery, which may be detrimental to the patient. So one must be aware of these and keep doing millimeter by millimeter and take your own time and keep doing it. Now, as you follow the steps of this principles of the surgery, the tumor itself starts behaving friendly with you. They start getting separated and they start coming to you and they start helping you to excise the lesion as shown here. Now you see the surface of the tumor, superior part of the tumor starts getting separated from the subfrontal region, from the optic chiasm, and you see the arachnoidal layer there, which separates the tumor from the important supracellular neurovascular structures, as I mentioned to you just now. Now you see the capsule from the right side is getting separated, and we are dissecting the tumor from the opposite optic nerve, that's a right optic nerve. And again, the part of the tumor which we have debulked, we have dissected, we debulk again. So devascularize, dissect, debulk, again dissect, devascularize, debulk. These are the 3 or 4 important steps of microsurgical excision of these lesions. Now I want you to see superior part of the tumor is getting easily separated from the superior part, that is optic chiasm, and the circle of Willis, anterior circle of Willis, which is formed by anterior cerebral artery A1, anterior communicating artery from both sides, the anterior cerebral artery from both sides, anterior communicating artery, middle cerebral artery, and ICA bifurcation, and ICA form the anterior circulation of Willis. And preservation of these branches and the perforators originating from A1, ACOM, and M1 are of great help. It's of utmost importance. We should keep all the perforators intact because A1 perforators, we call them. Now you can see the whole tumor capsule is separated. Arachnoidal plane is well maintained. Clarity is there and tumor capsule is taken out completely as you see here. Now you are seeing the right optic nerve, left optic nerve, optic chiasm, and in between the two optic nerves, that's the interoptic space, you are seeing the pituitary gland. Now, on the right side, you can see the tumor getting separated. After the separation, you cut the arachnoid and you see the opposite A1 on the right side A1 and left side. This is the right side A1. At every stage of surgery, we keep washing the area with pepperine saline. This is of utmost importance because to prevent the vasospasm due to surgical handling, thermal injury, and mechanical handling. That's the A1 on the right side, A1 on the left side. This is the anterior communicating region. And you see in between the two optic nerves, the ball dissector is demonstrating or showing you the pituitary stalk there. That's a pituitary stalk, which is originating and going down the pituitary gland and the thalamus, hypothalamus. Now you are seeing the dorsal surface of the optic chiasm and this is the lamina terminalis, thin transparent opening. Once we do that, now we bring in the endoscope because the suprasellar meningiomas, usually they will have the extension of the tumor in just behind the optic nerve into the optic canal. So at that juncture, we cannot see the optic canal and optic nerve. So we bring in the endoscope and look 360 degrees around the optic nerve and look for the tumor going inside the optic canal and optic foramen. And if it is there, you need to drill the anteroclinoid and the de-roofing of the optic canal and taking out the tumor completely. At the same time, you are seeing the anterior cerebral arteries and the perforators. In this person, the extension of the tumor is not going into the optic foramen and optic canal. Now you see the A1 on both sides, recurrent artery of Hübner's, and that is the origin of the tumor. And you can see the optic nerve. That's the origin of the tumor. And all these cases, this is the optic nerve, keratotic optic space, optic nerve, and there's no tumor in the optic canal here. Optic nerve is lax on both sides, no pressure. This is the carotid artery and complete excision of the lesion. Now you see the tumor is originating from here. This is the origin of the tumor. And all these cases, we prefer and we should do Simpson's type 1 excision, meaning that dura mater where the tumor originates, we need to cut, dissect it out and take out completely. And the origin of the tumor, we can coagulate, cauterize it with monopolar and kill the tumor cells which are infiltrating into the dura as well as the bone. Sometimes if there is a significant amount of evidence that tumor is eroding the tuberculum cellae or plenum cellae, you can use or you can drill the tuberculum cellae and plenum sphenoidal, or you can use the bone CUSA and debulk the tumor and burn the area with monopolar coagulation to kill the tumor cells as much as possible from the origin of the tumor. During this process, we must remember not to injure the surrounding important neurovascular structures because we are using the monopolar coagulation. Again, as I mentioned to your high illumination, high magnification. This is the end of surgery. Now you can see the pituitary stalk here, optic nerve on that side, right side, optic nerve on the left side, olfactory nerve is very well preserved, and I keep washing the area with pepperine saline to prevent postoperative vasospasm. That is the end stage of surgery. Lesion is taken out completely. Dura mater is brought back and closed as much watertight as possible. Sometimes dura will shrink. We use the pericranial graft to close the dura, and bone we fix it with the 20 or 30 ethylon, or you can use the plates. This is the postoperative scan showing complete excision of the lesion there. and no hemorrhage. We do the CT scan. We prefer all intracranial surgeries. We made a policy that same day evening before we go home, we do the CT scan, confirm that there is no post-operative complication like hemorrhage, infarction, edema, swelling. If any of those things occur, immediately we can attend before we go home and tackle the problem on time without causing the neurological deterioration. This is our post-operative clinical status on day 2. All these patients, we take a written permission and the consent before we publish their thing. And they're very happy to share their things because they have been relieved of their problems. They don't mind. Her glaucoma score is 15, no neurological deficits. And see, vision in both the eyes is very well preserved. Now you can see she is counting the fingers at the distance of 2 meters in the right eye very well. And she's showing with her hand. This is left eye. She is showing the vision, counting the fingers. So we have preserved the vision and improved the vision to some extent. This is our neuroanesthesia team, our treating physician, and neuro-rehabilitation team. And we have the presence, as my dear friend, Professor John mentioned, for the last 2010 onwards, we have been sharing our work on the YouTube. We have got the channel, that's a Neurosurgical Video Atlas channel on our name, where we have till today, we have crossed more than 590 microsurgical endoscopic navigation guided educative neurosurgical operative procedure videos. And that is where we'd like to share and learn from each other. And with this, what we have been doing is we keep getting the feedback all over the world. People, my colleague neurosurgeons, my junior neurosurgeons, senior neurosurgeons, they discuss with us online and give their feedback. And many a times, senior neurosurgeons, they give me a few more tips, good tips to improvise and improve the steps of surgery and improvise the demonstration of the surgery. It is helpful to me as well as the younger generation of neurosurgeons. To some extent, from my side, our side, I thought it's our duty to share and learn from each other. This is the end of the stage. Thank you very much for viewing. Any questions, any discussions? Now, I think we can go ahead and discuss the things.
Dr. Suresh, excellent
Yes.
Demonstration and
Thank you,
wonderfully
sir. Thank
dissected out.
Yes,
And
thank
I'm
you.
very pleased to see your technique. And
Thank
as
you.
most of us do the similar kind of situation, I
Yes.
just want to ask you a few things. If you,
Yes.
not the particular case in this particular, when a lesion is going below the optic nerve, going across the optic nerve, then adherent to the carotids, and also adherent to the cavernous sinus or entering into the cavernous sinus. How do you tackle those things? What
Yes.
do you do?
Yeah. No, sir. It is one of the burning questions and a very important practical question what you have brought up. Very important for the younger generation to know. If there is an evidence of two things. First, one by one, I'll address your question, sir.
Yeah.
If there is an infiltration or adherence of the tumor to the optic nerve and optic chiasm, if it is not getting dissected well, we leave it off to the adherence to, because what happens is there will be some amount of capillaries and blood supply to the carotid optic nerves and chiasm. And if you are enthusiastically start doing that, they may cause the visual impairment. And see, majority of these lesions, they don't come to neurosurgery. I'm sure you are a very senior faculty of neurosurgery from whom we keep learning at every meeting, sir. And see, majority of these patients, they don't come to us directly. They go to ophthalmologist because of the vision involvement. Now, what happens is that how you excite tumor, they're not bothered. They want their vision back and they want their vision to be preserved. That's all. That's their requirement. In that bargain, if there is a small lesion adherent to the optic nerves and chiasm, and easily, if it is not coming easily, leave it there and we can subject them for gamma knife or cyber knife. Number one, that's question. Second, sometimes the tumor gets into the carotid artery, wall of the carotid artery, and erosion of the carotid artery. And I showed in the beginning, these lesions, before we take up for surgery, we prefer, and again, you do that, I've seen that, they need to have a MRI angiography is a must in these patients. MRI angiography that shows the location of the carotid artery, the shift, and the involvement of the carotid artery, encasement of the carotid artery. So if those situations, if you find, and if you find that tumor is firm and not coming out well, adherent to the carotid artery, don't proceed. Two options we have. One, leave it there. Number two, if you have, before the surgery itself, you have noticed this problem, you do ECIC bypass. High flow bypass, and you can sacrifice the artery along with the tumor. Second option. Third question, when it gets into the cavernous sinus, at that juncture, we flush with the wall of the cavernous sinus, you take it out, and remaining part subject for either gamma knife or cyber knife.
Thank you. I had recently a similar problem just a couple of days ago. I was doing a large meningioma.
Yes.
It was difficult to know where it was arising from. It was
True.
coming from the basal dura, and it was such a firm tumor. Very difficult to cut with the CUSA. Only cutting was possible with the knife. And went on, and few hours we were not able to separate it out. And then we took it out. At the end of this, after separating from the carotid, found that the PCOM, posterior communicating artery, was literally going through the tumor. And we didn't realize before surgery that it may be going through the tumor, and started cutting. And very much adherent to the cavernous sinus. While stripping out from the cavernous sinus, it started bleeding torrentially. Although cavernous sinus bleeding is not a problem, but sometimes in presence of a tumor, they are very vascular and they can cause a lot of trouble. So these are the problems which we face. And I really wonder, do you feel that these are good cases to do transnasal endoscopically?
Again, you have raised a very important question and a very important practical issues. Yes, sir. See, of late, say maybe about a decade now, many authors in the world, including our country, in all over the world, they are doing endonasal endoscopic excisions.
Yes.
Now they're doing it through the endoscopic approach. Now, if the tumor is in the midline and not getting into the optic canals and cavernous sinus and going laterally, straight suprasellar and in the midline, you can do that endonasal endoscopically. If the tumor is off the midline, going anteriorly, laterally, posteriorly, involving the carotids and anterior circle of Willis, and on scan, it shows that the circle of Willis is encased by the tumor, I prefer to go transcranially. Because, sir, you know that we keep hearing you. See, transcranially, we have multiple corridors to access these lesions. One is intraoptic corridor between the two optic nerves. Second, between the optic nerve and carotid artery, carotico-optic corridor. Third, behind the carotid artery, retrooptic corridor. Fourth, we have subtemporal polar. Sometimes, if the lesion is going into third ventricle more superiorly, you can access through lamina terminalis. So these approaches may not be possible endonasal endoscopically. So as a surgeon, we need to understand the tumor factor, and take your steps of surgery. You want to go endonasal endoscopic or you want to go transcranial. So looking at the imaging and the clinical manifestations, you can take a call.
I find really difficult to do nasal transendoscopic pituitary
The
meningiomas, because you
supramenningiomas.
don't know how the characteristic of the tumor is going to be, even though you may have studied the MRI very well, and you find you are not able to debulk it, and you have to cut it, it bleeds. So sometimes I really wonder whether it is worth doing that, or just go ahead with the intracranial procedure, which is much more comfortable for us to do it. I know people are demonstrating very well, but these isolated cases, which are the firm tumors, not able to dissect it out, large tumors, very well. Only advantage of doing the endoscopic is the visual deterioration is less likely to be with the endoscopic than the transcranial. But well, when you're dissecting the tumor, it becomes very difficult out
Yeah.
because the approach is very. This is my
Yeah.
experience. I'm just sharing.
No, let me confess and be honest. What philosophy you have, same philosophy I have, sir, all the time. Now, see, people do it. Many authorities in the world, they do it in India and abroad, all over the world, they do it. See, the issue here is they call it as minimally invasive approach, transnasal approach. But see, the issue here is you are destroying the nasal mucosa. You are destroying the septum. You are destroying the sphenoid sinus. And you are drilling the skull base, bony skull base, which you are not replacing back. And you are doing the Haddard's flap, mucosal flap, denuding the nasal mucous membrane and using it as a graft. Just you have no scar on the face. It doesn't mean that it becomes a minimally invasive. It becomes maximally invasive, maximally destructive. Then subsequently what happens is these patients need to go to ENT surgeon almost for 3 months to 6 months. Nasal douching, nasal clearance, nasal care, septal crusting, infections. And imagine a simple, clean pterional or supraorbital craniotomy, excision, fixing the bone, and that's it. None
And
of these
CSF
issues.
leak is and the
Practically.
CSF leak is about 10 to 15% in this Hadas flap. 10 to 15%.
Some
They
people,
have to reopen.
some authors mention about 22 to 28% CSF
Possible.
leak, which is going to be very difficult to
Difficult.
very
Repair
difficult
it.
to manage, repair it. So all these issues, I personally feel, sir, I must confess, we have done about more than 21 or 23 cases of endonasal endoscopic these tumors, supracellular tumors, planum as well as tuberculum cellae. But somehow, as you rightly said, I also got discouraged doing this. Now, even though the tumor is small, even the tumor is midline, within 1.5 hours, without any issues, we go transcranially and take it out. That's it. Again, it's all
Right.
your, yes, that's right.
Very nice. Thank you very much.
Thank you, sir.
Anybody has a question, please feel free
Sir,
to ask.
one more question you raised about
Yes.
the claiming endonasal endoscopic access.
Yeah.
Preservation of the vision is better. But of late, few studies have come comparing the endonasal as well as the transcranial visual status. They find there's no change in between in these two cases. What is important here is, sir, we must understand these people do the small tumors, very small tumors, and direct supracellular. So obviously the results are going to be better. But the present studies literature shows that this is not the tumor itself which is important. The adherence of the tumor and the consistency of the tumor, which makes either you go transcranial or you go endonasal endoscopic, that determines the visual outcome, not the access. Because you go endonasal endoscopic and tumor is densely adherent to the optic nerves and chiasm, you're definitely going to have we are going to have visual deterioration in the process of excising it. So present literature, what the papers which have come in last about 5 years, about 4 or 5 papers are there in Journal of Neurosurgery and Neurosurgery from US. They claim the same thing. There's no much difference between the both transcranial as well as endonasal endoscopy, because there is a disparity in doing these cases. Transcranial, we do complex problems. Whereas endonasal endoscopic, they do straightforward supracellular and take it out. So you cannot compare the results in both the cases.
Very nice, very nice. Good discussion. Thank you.
Thank you, sir. Thank you very much. Thank you.
Okay, any other comments or questions from anyone in the panel? You can just text the question if you'd like. Well, I'd like to thank Harshad for providing the interactivity, because Dr. Dugani, if you have interactivity, it kind of raises other points that other people can relate to that are listening. I really think that Zoom hasn't been. Oh, we have a question. All right, Ganham Das, you want me to ask a question? You want to ask it directly?
Hi.
Go ahead.
I don't have any question, Dr. Dugani and Dr. Harshad. I'm the neurovascular fellow at the University of Toronto, here in Canada. And I appreciate the best discussion. I'm not from neuro-oncology team. Meanwhile, but I really appreciate. I used to follow Dr. Dugani's mostly all those videos and the highly meticulous steps he's following. Really, I do appreciate this. I'm highly honored to have the participation over here today. It's the morning time in Canada, so just the morning tea and breakfast and Sunday. So really, it's like a Sunday celebrations. So I got really the best exposure and orientation as an introduction to great surgeons. Dr. John, I appreciate your efforts, okay, to make it possible. Dr. Dugani from the India, whenever I have, supposed to have some friends for the surgeries, for some discussions, or for some even the patient's point of view, I used to recommend your great NAM to just discuss with you, as well as for next steps for the surgery or not. So again, I don't have any question, but just appreciations for both the surgeon, Dr. Harshad and Dr. Dugani. I'm so thankful and I'm so honored to be here. Thanks.
Thank you. Thank you, Dr. Gulsham. It's very nice of you. Thank you very much. Thank you.
Thank you.
Thank you.
Yeah, I think we'll get better at this interactivity. We're just starting, but I think you're going to see Zoom groups getting smaller, which is okay. I love to have a webcast like this where there's just 4 or 5 people, because it really gives the potential to learn more, I think. But we'll see. We're going to try our best.
Yes.
And I see, Dr. Dugani, you're going away for 2 weeks. So you're
Yes.
going away can you tell us where you're going to go?
Yes. 17th and 24th, we'll meet again.
Okay, very good. We look forward to that on the 17th. And
Yes.
thank you very much, Harshad, for providing the interactive atmosphere. And we'll
Thank
see
you. It's my pleasure. My pleasure. My pleasure.
Okay.
Dr. John, I must mention that Harshad, Professor Harshad sir is our what you call our neurosurgical mentor, and he's such a senior person. We keep every meeting we go, we keep listening to him and we keep learning from him. Indeed, it's a very great pleasure to have him and interact with him, sir.
Well, Harshad has always been part of the neurosurgical TV group. He's one of the first ones, I think,
Yes.
that really began using it, and he uses it religiously now. He's helped me out tremendously with with Ben's webcast. So we look forward to seeing you Prakash on the 17th of November.
Yes, sir. Thank
Thanks,
you.
Arshad. and Thanks, everyone else.
Thank
for
you.
coming.
Bye bye. Bye bye. Bye bye. Bye.
Bye.
Thanks,
Have
everyone.
a good day to everybody. Good day to all.
Thank you,
Good
sir.
day to you all.
Thank-
Bye.